Good evening, ladies and gentlemen. It's truly good to be present in a physical meeting and reconnect with all the colleagues and meet everybody in person. And I must thank the organizing committee for arranging this meeting with such a gusto and such a positive energy, which has made this meeting truly enjoyable. Thank you very, very much. I think the job description that I hold today is to put together certain case capsules with a clear, defined learning points so that the management of hypocalcemia becomes sort of pertinent and becomes clear as well. Hypocalcemia and its management is something which many of us as practicing physicians would encounter, and I will just fall back upon several cases that we have looked after in the department and sort of take you through the messages. When we are talking about calcium as a homeostatic mechanism, it is absolutely imperative that we look at the rest of the parameters like phosphorus and albumin, and it was alluded very clearly earlier as well that it's rather sort of disheartening when you don't have these rest of the parameters which are missing, which makes interpretative value attached to hypocalcemia rather difficult to interpret towards the diagnostic yield. We all understand that the calcium homeostasis is very tightly governed in the body, and hence any calcium which is less than 8.5 becomes hypocalcemic, as we are aware of the normal range. But we should be very clear that beyond the range of calcium or calcium as an actual number, we should look at certain additional parameters, by which we really mean that the binding protein related abnormalities and acid-base status of an individual. The classic example of which is, even in a seemingly low calcium, is a state of pseudo-hypocalcemia which emerges because of the loss of binding protein, which can emerge from patient with cirrhosis, malabsorption, or a nephrotic syndrome. And of course, never to miss a fact that we all have encountered this young lady presenting with carpopedal spasm of an acute onset with a normal calcium, which has emerged because of acid-base disturbances and the binding of calcium which is altered in this individual. So just looking at calcium as a number should be thought about beyond its boundaries of binding protein and the acid-base status as well. Calcium-related manifestations in its low state are basically governed by cardiovascular manifestations, the central nervous system-based manifestations, and the ocular manifestations. The manifestations in an acute state are slightly different than the manifestations in the chronic state. In acute state, one encounters even seizures, laryngospasm, and occasionally even a death is something that we have seen as practicing residents in the hospitals like KEM. But unfortunately, the chronic hypocalcemia is extraordinarily subtle in its manifestations and not very easy to pick up from the symptom complexes till it comes back to us as one of the parameters of assessment, and we glare at it as one of the findings. Calcium homeostasis is governed beautifully well in the body, and that falls back on vitamin D and its metabolism, parathyroid hormone and its functional state, and also the bone, which acts as an extremely active organ in sort of giving to and fro from the extracellular space exchange of calcium. So when we talk about calcium, it is maintained in this tight homeostasis because of adequacy of vitamin D action, parathyroid hormone action, and the bone which acts in unison with these two parameters. State of hypocalcemia hence will emerge in any state which disturbs vitamin D, its availability, or its metabolism, parathyroid hormone availability or its sort of action profile, and bone which suddenly starts sequestrating calcium with or without phosphorus. So when we are talking about these different parameters which lead to hypocalcemia, it's absolutely essential when we look at the rest of the parameters, it yields to which is the domain which is going wrong, and that comes from phosphorus as a marker and parathyroid hormone as a marker. Vitamin D deficiency is typically associated with low phosphorus, unlike the other two states of hypocalcemia, which will have high phosphorus. And similarly, parathyroid hormone will again yield towards additional diagnostic clue, wherein vitamin D deficiency, it is elevated, and of course in a PTH deficiency state it would be on the lower side, and that would help us to put together the adequacy of diagnosis and hence the principles of management together. Vitamin D deficiency is what we would like to sort of just highlight with few of the case capsules. Here is a young teenager who comes with severe aches and pains, and she's got extremely severe muscle weakness, as very clearly discernible by the fact that she's sitting in a wheelchair. She has this very low calcium with low phosphorus and appropriately elevated parathyroid hormone. Obviously, we are dealing with some state of vitamin D or its metabolism related problem, and this lady actually had vitamin D deficiency because of celiac disease, and she presented with severe osteomalacia, pseudofractures, and a bad myopathy. This diagnostic yield is going to result in totally correctable pathophysiology, and the lady is going to do really well. Compare that to this two brothers and sisters who present at respectively 27, 29 years of age, and a little younger sister who accompanies them. Obviously, we are dealing with a genetic disorder which is leading to hypocalcemia with low phosphorus, appropriately elevated parathyroid hormone. But what is quite important in this patient is the fact that the vitamin D is normal. It is 125, the active vitamin D, which is on the lower side. Here is a genetically transmissible disease which is leading to vitamin D dependent rickets type 1, which is genetically proven, and that stands sort of leading to deficiency of active vitamin D and hence the absorption of calcium from the gut. So 25 hydroxyvitamin D was very, very normal, but because of this enzyme deficiency, the patient cannot synthesize 125 dihydroxyvitamin D, leading to such severe bony deformities and a crippled state as a young adult. Again, a genetically transmissible disorder present in two siblings with severe hypocalcemia, low phosphorus, but now vitamin D is very high. Also, 125 is very, very high, telling us it's a VDDR type 2, and of course, generalized alopecia was again reminiscent of that particular problem that we were facing in this patient, and it told us it was vitamin D dependent rickets type 2, again genetically proven with a mutation which is positive, and here we have adequate 125, but the missing action of 125 producing VDDR state type 2. Parathyroid hormone related deficiency leads to complete disbalance in terms of sort of disturbing both the absorption of vitamin D, bone remodeling, and bone unition in acting and maintaining extracellular calcium levels, and of course the excretion through the kidney, all the parameters of calcium homeostasis which get disturbed. So here is an example of a lady which presents in mid-50s with a GTC. It doesn't get investigated and the patient is just put on an anti-epileptic. On anti-epileptic, she again presents with a GTC where the rest of the parameters are put together, and here is the story. Calcium is extraordinarily low. Phosphorus is clearly elevated at 7s and 5s. And the parathyroid hormone, which is totally inappropriately on the lower side in presence of such a low level of calcium. Here is a definite state of hypoparathyroidism, as shown to us also with a basal ganglia calcification, but we don't know the cause of hypoparathyroidism, calling it idiopathic hypoparathyroidism. But here is a similar situation of hypoparathyroidism, which is emerging after surgical total thyroidectomy. And what needs to be understood and related to is the surgery and presence of hypocalcemia can be extraordinarily dissociated in the time frame. And one can never miss the scar of the surgery, which talks to us as a possibility of operative damage leading to hypoparathyroidism. It comes in huge shade card, and it can be just a state of transient, very mild hypocalcemia to a state of permanent hypoparathyroidism, which can be severe. And that is truly a difficult disease to treat, as we will see during principles of management. Parathyroids can also get sort of damaged with autoimmunity and autoimmune polyglandular endocrinopathies, like in these two sisters who present with hypoparathyroidism, Addison's disease, and hypothyroidism associated with candidiasis, which is autoimmune polyglandular syndrome type 1. So these patients can present with status epilepticus because of hypocalcemia, where it becomes necessary for us to look for other endocrine gland related dysfunctions, or a genetic syndrome which is associated with other components of syndrome like deafness in these two brother and sister, and of course drug-induced hypocalcemias which act through different mechanisms. And in this particular patient, amphotericin-induced hypocalcemia, which is because of hypomagnesemia, where magnesium has a state of functional hypoparathyroidism leading to hypocalcemia, which is what we should be aware of, because calcium correction alone may not work in this patient, and magnesium will have to be corrected as well. It's amazing how congenital disorder with which the patient is born can present at any age in a given patient. Here is a young lady who presents with hypocalcemic manifestations, which is very representative of hypoparathyroidism. So far so good, and we would have called her hypoparathyroid. But she also had a renal calculus disease, which was little kind of out of context with hypoparathyroidism, and that led to renal calcium excretion studies which show that there was hypercalciuria. And here is a lady who has autosomal dominant hypocalcemia with hypercalciuria, a congenital disease where there is a state of functional hypoparathyroidism with the set point of PTA secretion which is altered and shifted to the left, leading to hypocalcemia. So no age is barred from representing a congenital onset of hypocalcemia is a message. Here is a very young girl with high phosphorus and a low calcium who has carpopedal spasms, and that's why the biochemistry is put together. But look at her symptom complex. She also talks about pain in the knee joint, which leads to X-ray of the knee joint, and she has this calcification, and she walks with the knee, which you can see the way she positions the knee at rest. She's never bearing weight on her left knee. And also her parathyroid hormone is elevated. This is a state of pseudo-hypoparathyroidism, a state of functional parathyroid hormone deficiency because of different reasons leading to hypocalcemia with phenotypic features which allow you to discriminate them, and of course the parathyroid hormone which is elevated, giving us a cue towards diagnosis. Same case with ectopic calcification, which you can see over here as a bump on her sort of foot, which led to a cue that this could be a state of pseudo-hypoparathyroidism. So hypocalcemia, moving away from parathyroid hormone, can also come from bone sequestration, and we all have encountered this particular kind of pathology, where removal of this, in this particular case, a very large parathyroid adenoma within 24 hours, the patient starts presenting with acute onset symptom complex of hypocalcemia. And we all have gone through this picture of hungry bone disease, where we have now learned to anticipate and even put together a therapeutic regime to prevent it and not let the patient go through this kind of a symptom complex, which is truly very, very disturbing to the patient. Seemingly innocuous drugs like phosphate-containing enema, which is used as a pre-op preparation in a patient with an acute load of phosphorus, especially in a background of compromised renal functions, can lead to a state of hypocalcemia, which can be symptomatic, and that should be borne in mind as well. So phosphorus enema, phosphate enema induced hypocalcemia is what was a presenting feature in this particular patient. So sudden load of phosphate, which can come from enema or a tumor lysis syndrome, is also something that we should be aware of. Management principles in acute hypocalcemia are governed towards relieving patients from acute symptom complex, and they would be necessitating calcium infusion rather than bolus-based regimen. Also, they will require simultaneous introduction of high dose of elemental calcium, active vitamin D as well. And if this regimen doesn't respond, you would need to look at the magnesium as well as a background in case there is a magnesium deficiency which needs to be corrected as well. So acute hypocalcemia is best treated with calcium infusion in a symptomatic individual, along with infusion-based regime and oral regime, which are started simultaneously. However, a chronic stable hypocalcemia, however severe it may be, need not have IV calcium infusion as a goal post of correcting it. The correcting principle over here is avoid any aspect of symptomatic hypocalcemias, maintain calcium in the lower range of normal, and never allow complications because of therapeutic regimen like hypercalciuria, which can lead to very unfortunately chronic kidney disease in these individuals, which is what we have seen in the past. So chronic hypocalcemias require long-term management and long-term monitoring, as shown in this particular slide, where calcium gets of course corrected, but we ought to be very, very conscious of the fact that we don't produce hypercalciuria in these group of individuals. And the treatment is of course with active vitamin D and elemental oral calcium based regimens. So just putting together synopsis to tell us about how does one arrive at a diagnosis and hence put together an optimum treatment as a principle of learning is vitamin D deficiency will be associated with low phosphorus, PTH-based hypocalcemia, which are actual PTH deficiency or resistant state, will have high phosphorus, and of course inappropriately low PTH as a number, whereas PTH resistance will have a high PTH. Bone sequestration has a little different sort of phosphorus levels and PTH levels, and we would need to look at the background element of understanding what has led to bone sequestrations. So hypocalcemic disorders are very amenable to treatment, and one would like to arrive at the right diagnosis to offer the right management to our patients. Ladies and gentlemen, thank you very much for your attention.